Thank you. Thank you, first of all, to the board for having me talk on this intriguing topic of value-based healthcare. Value-based healthcare is actually an international wave that is ongoing in healthcare, but actually not so much in dermatology. And I believe that psoriasis is a top example disease. It could be like a poster child disease to start applying this paradigm on. Let me explain. We all are psoriasis adepts, otherwise we wouldn't be here at the IPC. We know it's complex. We know many aspects need to be taken into account. We know that the treatments are there, but are quite expensive, so cost is sometimes an issue. And like in every area in healthcare, the management of the overall care cycle could be better in certain environments. So PLUS is a concept we set up in Ghent, where I work in the academic hospital, university hospital in Flanders in Belgium. And it's actually a dedicated clinic for psoriasis patients. And in 2012 already, we were aware of the fact that there are so many data on psoriasis, like on the comorbidities, sorts of treatments that your patients may need. And we started working with a structured checklist, not forgetting anything to be asked to the patients, which implied that we needed more personnel to gather all those data. So I started working with nurses, but also administrative personnel was helping in setting up the biological startups and follow-ups. So it took more time, and we also put more emphasis on education. As Claudia was alluding to, patients do need I would say a higher health literacy, so we also put emphasis on education. And last but not least, okay, you see your patient in a consultation, but sometimes it goes wrong in between consultations. So we offered the opportunity to contact us in between consultations so that it is a continuous flow of care. We had good results, as you can see here. We even published it in several occasions, but I got a comment in my department, to one nurse, two nurses, the secretary is also helping you. You are spending a lot on your SOPLUS. Maybe we should put it in skin cancer clinic. So I was like, yeah, but I get very good results in my patients because of all the measures we had taken. But I had to admit, on the long run, when we look at psoriasis, the costs are high. Looking from a society perspective, biologics do cost a lot, for instance. Comorbidities, when you don't take care of them, you get a lot of secondary healthcare budget taken up. And there I was thinking, well, we do some prevention of comorbidities by our setup, so we might be saving on the long run. And also, if you know our work, what we are also doing is we do personalized dosing of biologicals, because we had detected that 1/3 of our patients, for instance, on adalimumab, are actually overdosed. And you can do it with a lower dose, so less injections, so saving money there. So we were cost aware, but we did put in a lot of resources. So I was coming to a point, okay, we have outcomes, we have good outcomes, but there is also this cost perspective. And it was actually my colleague, Jan Guttermuth from Brussels, who was sitting here, who said, have you heard about value-based healthcare in 2017? And I was really intrigued by this concept. The concept comes from Michael Porter. I will show you in a minute. But meanwhile, we know in general in the world that the costs in healthcare are rising. Of course, not only in dermatology, but everywhere. So it is becoming also our responsibility to do something about cost containment. And then also what is going on the last years is a high level of digitization. So why not use it to have some better analytics on our patients, also in electronic health records. It's an instrument that we can use for the better. And also, as we heard also from Claudia, more patient-centric care is definitely needed. This is the paradigm of value-based healthcare. If there is one slide that you need to take home, it is this one. The value that we obtain in managing our patients is actually related to the outcomes that we should be measuring. I will come back to that. over the costs. So the costs to get those outcomes at the best possible way. And Michael Porter and colleagues, also Elizabeth Theisberg from US, they came up, I would say 15 years ago, with the value agenda, and you should follow those 6 points. And I will go over them very shortly, starting with number 1. You have to organize yourself into an integrated practice unit. This is not just working in a multidisciplinary manner, which we definitely all do, but working in an IPU is you choose a condition like psoriasis, but it can also be diabetes or knee replacement, or so a well delineated medical condition, and you organize the full cycle of care around this medical condition, including education, engagement, monitoring, adherence, and follow-up. So you organize a common organizational unit, and then comes back that outcomes and costs are important, and with the team that you have around it, you come together to discuss the outcomes, but also to discuss on the costs and where you can become more efficient. This is an example of our PSO Plus, how we are organized. So we have a preferential circuit in the darker blue with rheumatologist, psychologist, and dietitian, and then less frequently we need the larger ring around it, the obesity clinic, smoking cessation unit, etc. So we are in the lead. When a patient comes to us, we are sure that a patient cannot make all the appointments for the comorbidities him or herself. We need to organize this for the patient, and that is what we do. So we have slots in those departments where patients can, without any delay, be referred to. An integrated practice unit is not just working in a multidisciplinary way. When you really do this very deeply, you might even become like an independent unit, also managing your own budget to manage these patients. But this is already the ultimate IPU. So you see several aspects that are important when you organize yourself in this way. But for me, this is really the future. So we published our PSO Plus recently, the integrated practice unit. All the documentation is in the left publication. But I will also show examples from outside of dermatology, like for prostate cancer. The Martini Clinic is a famous clinic in Hamburg, working in a value-based healthcare manner. And there is also this publication on organizing yourself in primary care. And okay, I talked about the IPU, and you might sometimes recognize yourself on the most left upper panel. This is working in a multidisciplinary manner. So you have all the departments where a patient should go next to one another, but furthermore, you have not really a link between the departments other than you make a phone call to make an appointment for your patient. And then more going to the right, you see that it's becoming more an overall full cycle of care over the departments. And sometimes the departments, like in the integrated practice unit, even disappear. So the patient does not feel, now I go to this department or to that department. In the end, it feels like he comes to a unit that is only managing everything around, for instance, psoriasis or diabetes. So again, this equation. Let me talk about outcomes and costs, what you should do. And Porter said, okay, outcomes, you can have clinician-reported outcomes, the hard endpoints like disease severity, but there is also the patient-reported outcomes. And we have made an outcome set, we published it on for psoriasis, really building further on all the work that has been done by IDEOM, by OMERACT, by C3 and CORD. So they produced a lot of information on outcome items and also on instruments, and we thought, well, maybe it's time to make it usable in daily clinical practice. So what we did is a systematic review, out of which came 21 outcome items, and we also in the outer shell show how you should measure, for instance, treatment safety, disease severity, also symptom control, for instance, but then also patient-reported ones. So I can say that we use 12 instruments to measure 21 outcomes. And why is this an example of value-based healthcare? Well, because these outcomes are measured for one medical condition. So it's not like quality measures that your hospital is measuring in, I would say, for instance, wound dehiscence is something our hospital had to measure as a quality measure for our hospital. But I really didn't feel connected to that. It didn't say anything about the quality of the care my department was giving. Outcomes should reflect the full cycle of care, multidimensional, must be relevant to patients, so not only reported by patients, but being relevant to patients. And what is good here, when your patients enter and you measure this, you immediately have a kind of risk stratification. You will have patients that do very bad in this outcome set, which are probably the more difficult patients, and you will have some that are better from baseline on. Does this exist already? Yes, as I told you, dermatology might be lagging behind a little bit. You see here the website of an organization that is actually derived from Michael Porter's paradigm. It's called ICHOM, the International Consortium for Health Outcome Measures. And they have now in about 40 diseases what they call a patient-centered outcome measure set, or a harmonized outcome measure set. And the intention is that everyone around the world starts measuring this set, because it's important. Then you can benchmark your own center versus a center in Singapore or a center in US when you live in Europe. And you can see that no dermatology condition is included yet. This is an example of an outcome set for stroke, for instance, stroke recurrence, but also motor functioning, quality of life. So it's always the same patient-reported and clinician-reported outcome set that comes back. It also exists there for inflammatory bowel disease. And I really know the people from IBD that have been making this set. And it's not just a commercial organization. What is behind is that they collaborate with the professional societies, like ECHO in this instance for IBD. And you see that all the experts in IBD have been working on this outcome set. So it might be one idea to come up with a set for psoriasis, link it to ICHOM or not, but at least it would be good to have this outcome set. This is an example of the Netherlands. They measure outcomes there through an organization that is called the Happy app. And there is also a Happy Skin app. And always the same domains come back. I think it's difficult to have a Happy Skin app and not specifying for which disease. I think you should be more condition specific. But patients can follow up themselves on the app how they are doing. This is from my clinic. We apply a treat to target paradigm. So a patient should do well in 9 targets, and here I see that my patient only gets a 3 in 9. I can also show it to my patient, so we have to work better. So when I see this result, to me this is a trigger to adapt my treatments a lot. So make it more visual. Okay, these were the outcomes. Let's go to the costs. In value-based healthcare, they try to really measure the true cost of all what you are doing. You heard me say you work with a nurse, 2 nurses, I take more time. So this comes along with a cost. What you do in value-based healthcare is you apply time-driven, activity-based costing. So this comes from the accountancy world. But what we do, we measure how many minutes it takes to check in the patient, to consult with the nurse, to consult with the dermatologist. So it's really the true cost, the minutes that you spend with your patient, either sitting in front of you or afterwards being virtually in contact with your patient. So this is how we measure. We we have a kind of application that is very easy to use to measure the minutes that we have in one patient. And why do you need this exact cost? Because only then can you calculate how much a code could be, and one of the coding systems or the payment systems could be a bundled payment. So why not tell to the government, I have a bundled payment proposition to follow up on a severe or a mild psoriasis patients, and it's called a bundled payment because if you follow up on a psoriasis patient for 1 year, you know exactly how much it usually costs, and we have this cost proposition. A bundled payment is something that comes back already in several diseases. It is set up to move you away from a fee for volume. So each time a doctor sees a patient, it's like not blocking you of saying to this patient, you don't have to come back, you are doing well, but you are also not rewarded for the good results that you get. So with a bundled payment, you become more cost aware, and you might be incentivized because you are rewarded for the quality. For instance, you could enter a quality rewarding part. When your patients do well, you might get a bonification within this bundle. Sometimes governments misuse bundles, especially this is the experience in our country, where the government has said from now on, for a simple appendicitis in a non-comorbid patient, this is the lump sum you get for treating the whole care path. We all know it's too low, and what happens then is that the quality of care is lowering. So it is not meant to lower the cost. People from US might certainly know a fee for performance because you have this alternative payment models. So to the left is the fee for service. To the right is really an alternative payment model where the bundled payments are introduced, and you might be rewarded for the quality and not penalized for not doing well. For instance, in knee replacement, this is an example from the Netherlands. They say to treat the patient over the full cycle of care, including everything that is needed. This is the amount of euros that I need, and it led to higher production capacity, reduced waiting times, continuous improvement because they are looking at the outcomes all the time, and a lower risk for reoperation, and definitely a cost reduction. So sorry, this was in Karolinska in Sweden, where value-based healthcare is definitely used as a model. Fourth and fifth point, I will be short. So move away from fragmented and siloed care. Don't duplicate services. When you have the overview of the full cycle of care, you can make an arrangement. You do this, I do that, so that you don't duplicate anything. And once your hub, like PSO+ has formed, you might also replicate it over your region and have multiple PSO+, so to speak. This is exactly what happens in the Netherlands for the diabetes IPUs. The initiative is called Diabeter, so doing better with diabetes, and actually they have hubs all over the country, but also in US they have the cancer centers, the MD Anderson cancer centers, which are exactly IPUs based on the value-based healthcare principles. IT is becoming more and more important. It is there to use. So when you start measuring outcomes and costs, you should ask to your hospital to have a good IT system to measure all this, and preferably the data should be connected to other centers also when a patient moves around, so that you can have an overview of the data of a patient in a certain region. And when you start measuring all this, you get a truly nice data lake of all the patients in your region, upon which you can again do research, apply artificial intelligence, for instance, to look for risk factors or cost drivers in your patients. But you can also use it to communicate with your patient individually on how he is doing. This is measurably better in the Netherlands. I won't go into detail, but they share their results, and by sharing, by benchmarking the results of your center with other centers, you might see where you are not doing so well, and then also go for a root cause analysis to see why you are doing less good than the other centers. Santion hospitals in the Netherlands definitely do value-based healthcare for 15 medical conditions meanwhile. And then we asked them what is good and what is bad in value-based healthcare, because probably there are also downsides, and you see the benefits on the left side, in the sake of time. And you see some barriers on the right side, and I must admit, okay, this is a wave that is ongoing. People are starting to work with outcome sets, designing them, measuring the costs, but if it's too early already to prove that it really has added value. But if you don't believe in it from the beginning, you will never know if it has an added value or not. Also, this colleague from Nijmegen says the value agenda from Michael Porter is a bit too limited. We should definitely also integrate value in the patient communication, but also install a culture of value delivery within the professionals. So it's really a culture change that is needed. And I believe that in certain conditions, not in dermatology, that they are really already starting to do this. So my summary, on occasions, value-based healthcare had already bad connotations, but we are only at the beginning of applying it. So everything you heard about value-based healthcare, try to do a reset. It's not an instrument used by pharma to justify the high prices they ask for certain treatments. We definitely need more validated patient relevant outcome sets, and a need for the insight in the true cost range to achieve those outcomes. I truly believe in this. And we might consider, for instance, major skin diseases. Of course, I mentioned psoriasis, but also for other diseases which have a quite high prevalence, we might start value-based healthcare principles. There is the beginning of a collaboration with IPC to validate the psoriasis value outcome set that I showed, which is published, but it needs to go to an international level because before we can use it everywhere. IPU models is team medicine with a physician and also a nurse in the lead, and we must take the lead to make outcomes transparent and continuously improve. I would say accept the digital challenge and join an upcoming international community on more integrated and transparent care. If not now, when would you do it? So do remember this equation, and there are also some interesting upcoming educational environments. I'm not involved in it, so I'm truly independent here. But if you would like to follow courses, there is one in Paris from EIT Health, there is one in Boston, also in Texas, and also an interesting summer course of 2 days in Rotterdam, which I will definitely attend. This is my team in Ghent. So I work with these young people who started believing in it from scratch. So I must congratulate them. But also Deepak Balak on top is an IPC counselor. He is now writing an interesting primer for you as dermatologists to get more acquainted with value-based healthcare. And we also had an IPC fellow from Chile who is also going to bring the paradigm one day to Chile, he promised us. Thank you very much.
Thank you, Jo, very much. Is there any question for the audience?
3 questions, yeah.
Yep. Huge challenge. I mean, it suits us fine. I mean, the concept is amazing, but I mean, how can we implement something like that?
Step by step. I showed the outcome set. It's 21 outcomes. It's huge. But also in the Netherlands, for instance, they started by only measuring a few and the most important ones. So I believe in step-by-step approach, yeah.
One thing at the beginning you showed the inner circle for psoriasis, and you put a dietitian inside.
Yeah.
Is this for losing weight, or I've heard you before talking about the relationship
Diet,
to psoriasis? What do you think about that?
It's a major problem in psoriasis. So I think it should be part of the core unit to give dietary advice, not only for losing weight, but also for the cardiovascular risk factors. So it's integrated. Yeah, thank you.
Professor?
Yes.
Okay. Yes.
Markus Schmidt-Egenol from Sweden.
Hi.
Thank you very much. I think all of us in the room are convinced that following up patient-reported outcome measurements is extremely important. My personal challenge is on the granularity to choose. And as you just heard, it can be really scaring to talk about so many outcomes. So what do you think about a very simple approach? If we say that medicine is integrated, we have showed the interdependence of comorbidities on the psychiatric and the somatic level in psoriasis. So it's really very complex. And you mentioned shortly, we should have a special measurement for every skin disease. But if we take it the total other way around and say, due to that things are interconnected, we should have a simple measurement like just the EQ5D, which is very applicable. So my question is, regarding that something has to be applicable longitudinally, what are the downside of simple measurements like the EQ5D?
We do measure EQ5D, especially we are running a trial. All the patients that come to our clinic now and that are new, we follow them up and we measure the value. But we also measure EQ5D because in the end you need some health economic proof that working like this for calculating QALY and DALY, you need it. And the discussion on what is value exactly is definitely one that we still have to make. We started this way, but there is also another example for measuring value, that is the multi-criteria decision analysis, which is also applied in skin cancer. I really look forward to have a discussion forum, which would be the idea to start within IPC, to have more discussions like I don't have an exact answer to your question.
Because the question would be, what is the additional value, the information you can extract of all the questions which you don't get by the EQ5D? And is it like worth it? Because, you know, we have all the problems that I'm running a register in Sweden, and to follow up over time, you really can't ask too much questions.
Yeah.
So the question is always, is it worth it to ask many questions if you may get nearly as good of an answer with a few questions?
I have, future will tell. Last question.
Chris?
Yeah. I think I get what this is about. I've spent all of my career working in sort of high-power medical centers and thinking about this sort of thing. And I've become increasingly convinced that the problem isn't in secondary care. I think we should be investing, in a way, in what Mahira is saying, in the community and managing psoriasis and other skin disease properly in primary care and community. And that's where you need the investment, probably rather than in secondary care. I just wonder how you can move the concept of value-based healthcare to community to get the same sort of results, and what sort of outcomes you would look at.
Maybe you didn't notice, but in the IPU circles, the GP is definitely involved. So we work more closely with GPs than ever. So, and it's in the system. They immediately get a report letter with some extra education on psoriasis. So they are part of the IPU. Is that your question?
No, it's not my question, actually. My question is...
on the patients themselves.
No, it's about so not GPs integrated into your system in secondary care, GPs and community health workers and nurses working to manage psoriasis before it even gets to secondary care. And a lot of patients don't
Okay.
even need to come to see us if they were managed correctly. Well, if a diagnosis was made early, the interventions were early, and the correct course of action was early, and they put in the right sort of lifestyle behavior change, etc.
Yeah.
I just think that's where the best value for money would come from, to tell you the truth.
The health system in Belgium doesn't allow this yet, so the MD is still in charge. What we do is reduce the minutes the patient spends with the MD, and enlarge the minutes with nurses and with. But it's not that we send them out to community. So I know in UK it's much more introduced already. Yeah.
Well, okay, thank you. It's really impressive work, actually.
Thank you.
And I'm from China. Well, I see that your IPUs can measure the outcomes and also the for every patient. But actually, in our clinic, we found that the elderly people may be hard to understand what we are talking about or feel all the questionnaires. So I just wondering that how your units can manage these elderly groups well.
By having a person on the floor, like a volunteer who takes care of the people that have more problems with the digital platform that we are using. So have some differentiation in terms of support, yeah.
Okay, okay.
Thank you.
Thank you.